Diabetes and CVS. Etiology and pathophysiology. Accelerated atherogenesis. This is the result of the following: dyslipidemia, increased low-density lipoprotein and triglyceride and decreased high-density lipoprotein; hypercoagulable state and increased platelet aggregation; hyperinsulinemia, in type 2 diabetes, promoting vascular smooth muscle proliferation; glycosylated proteins promoting the production of oxidants. Hypertension is very common in type 2 diabetes and leads to a disproportionate rise in risk of cardiovascular event. Endothelial dysfunction is the likely common final pathway resulting in macrovascular disease. Autonomic neuropathy. This causes impairment of the protective sensation of angina, silent ischemia, and may lead to prolonged ischemia, arrhythmias, and sudden death. Diabetic cardiomyopathy. Impairment of systolic and diastolic function independent of macroscopic coronary artery disease, possibly secondary to microvascular disease. Epidemiology. In people with diabetes, the risk of acute myocardial infarction is increased by 50% for a man and 150% for a woman. The rate of major complications is increased and associated with higher mortality rates. Clinical presentation. Silent ischemia may lead to atypical presentations, e.g. acute myocardial infarction as ketoacidosis. Treatment. Acute myocardial infarction. Standard treatment plus an insulin infusion, sliding scale. The absolute benefit of all standard interventions is greater in people with diabetes. Coronary revascularization. Diabetic coronary disease is generally more diffuse and distal, so that both coronary artery bypass grafting and angioplasty have poorer outcomes than in people without diabetes, appreciating that their untreated risk is greater. However, recent work suggests that coronary stenting, particularly drug-eluting stents, plus the use of a glycoprotein IIB/3A receptor blocker, antiplatelet, may improve results. Prevention. Primary. Good glycemic and BP control, 130/80 mmHg, and avoidance of smoking. Secondary. Treatment with a statin and an angiotensin-converting enzyme inhibitor, though most of this high-risk group should now be on these drugs as primary prevention.